So out of the pan and out of the pot and into the pan, we're starting onto preventives. And so these are the daily medicines that you're going to take to try to tone down your headaches. And what we're going to talk about today is when to start a preventive, what to consider, look at our traditional ones that we use and how can you select them rationally instead of just spinning the wheel and picking one. And then CGRP antagonists. We have a whole lot of updates on this, monoclonal antibodies, the GPANs, which can be used for prevention. And we're going to highlight the pros and cons differences of each. And then I'll just give you a quick overview of kind of what's in the pipeline. There's a lot of interesting molecules that are under investigation. So again, my warning, if you're going to see any data that's presented that's not Health Canada approved, you're going to have this little icon in the bottom of the slide, just so you're aware. So we've already done all my disclosures and everything. So if you want to see those and you're tuning in later, just go back to our slide. So when to consider preventive treatment, I would say, there's a lot of rules of thumb that people have, but if it's impairing their quality of life despite the use of acute medications, that's a good time to start it. If you're having more than 3 moderate to severe headache days per month and acute medications aren't working, that's a good way. I have two ends of people. I have, like I talked about my Aquarians, they have a headache 24/7, 30 days a month, and they still don't want medicine. And I think that's underkill. And then I had like some really type A judge type personality, and he had only 2 migraine days a month. But for him, it was the worst thing in the world. And he's like, I can't miss 2 days of work per month. I'm falling behind. And so he wanted to start a preventive that day. So I tell people, there's no hard and fast rule of thumb. For me, it's somewhere between 4 to 8 headache days per month, and it's causing a functional impairment. But ultimately, it's a decision that the patient reaches with you after talking about, pros and cons and balancing the options. So the goals of prevention, you want to reduce attack frequency, severity, duration. You want to reduce the associated symptoms like nausea, light and sound sensitivity, improve responsiveness to your acute medications, improve their function or like get them back to work, even if they still have a little bit of headache, reducing the cost of like emergency department visits, the patients are using taxis to drive instead of things, and preventing disease progression. This is a bit controversial, but the thought is if you leave migraine untended, it can get worse over time. In the trials, we look at mean monthly migraine days, and that's our prime metric. But to be honest, that doesn't capture all the other types of disability and other ways that these can improve their quality of life. So that's why I think some of the newer trials are looking more at patient satisfaction and work function and life function with family and home. Preventive medications, the traditional ones are here. I would say the mainstays are topiramate and propranolol are the classic oral medications, but there are lots that are very nice to try, like candesartan is very well tolerated, doesn't work well as an antihypertensive, so it's generally very well tolerated, even in people with generally good blood pressure. Botox is tried and true, and there's a reason people keep coming back for 40 needles in the head every 3 months, and that's because it works. And the other ones are these newer ones, the MABs and the GPANs. So we have our Canadian guidelines, which were published in 2012, and so they're getting a little bit stale now because they don't include even Botox or the CGRP medications. But we are waiting. Suzanne Christie and her group in Ottawa are coming up with our newest iteration. The trouble is, there's new drugs constantly arriving at this point in time, so it takes a lot of updating. So my tip for you is if you're selecting a preventive medication, I try to match comorbidities and give people kind of a 2-for-1 approach. So if you've got hypertension, you can try beta blockers, candesartan or lisinopril. These are ones that'll help with migraines and hypertension. If they're depressed or anxiety, venlafaxine or mirtazapine are good choices. And I find like it's off-label use, of course, but even low doses, like 75 milligrams that are not actually antidepressant level, can have a good impact on headaches. Also works well for things like vertigo and nonspecific dizziness when you've ruled out other causes. And so it can be quite helpful. Magnesium, I also throw in at the same time for vertigo and disequilibrium. It tends to have a significant effect in my practice, and I often pair it with venlafaxine. For our patients with bipolar affective disorder, because migraine does occur in this population at a higher rate, some mood stabilizers can be useful as a 2-for-1, like Topamax or valproic acid. And so you can also, if you're uncomfortable with these medicines, pen a letter to your friendly psychiatrist who's working with them. Fibromyalgia and other neuropathic pain types of central sensitization may respond to duloxetine, venlafaxine, or tricyclics. And if they're having particular insomnia, my preference for insomnia is to start with sleep hygiene and not with medications. However, if they're really in crisis, sometimes a little sprinkle of amitriptyline or nortriptyline might help them, at bedtime, both with headaches and with sleep, and just get them back into the regular biorhythm. And then you can wean it away after 6 months to 9 months. If they're having a lot of medication side effects, we all have those patients that say, I'm sensitive to every medicine, and I don't believe in multiple chemical sensitivity, but I believe people can be very sensitive to internal sensations. And I think the good ones are the ones that maybe, are not systemically absorbed, like Botox. And so that's an easier sell for them. Or the CGRP monoclonal antibodies, where we have large trials that show that they don't have a lot of side effects. We'll go over that. So how good are we right now, just as it stands? Like we talked about, migraine affects up to a fifth of the population. There's more than 1 billion people with migraine in the world. And in more than half of patients, there's a 5-year delay or more between the first time they manifest the migraine and when they're diagnosed. Only 30% of the people, even if you get over the hurdle of getting the diagnosis, only fewer than a third actually get the medicine when they are eligible for it. And at 1 year, fewer than a fifth of those people are still taking their prophylactics more than 80% of the days. And I think that speaks to a lot of the issues that we have with the traditional medicines. So looking at those side effects like Topamax, I tell people, well, this one is a bit of a hard sell, but I love it. Topamax is probably my most commonly prescribed oral medication. The trick is going very low and very slow. You break those tablets in half to 12.5 milligrams, and you let the patient decide if they want to increase it every 1 to 2 weeks by half a tab until you reach 100. And it can take a long while to get there. Then they have to sit there for 2 to 3 months to see if it works. Doing it that way, I find patients are much better able to tolerate it. And you avoid the brain fog, the tingling paresthesias in the fingers or face. You just have to warn them about, glaucoma, kidney stones, sometimes irritability, or even up to suicidal ideation if they have a history of that typically. And of course, it carries a risk of cleft palates in women of childbearing age. So you want to make sure they have good contraception. And so for all these reasons, I think many people are hesitant to prescribe topiramate unless they feel very familiar with it, like a neurologist. But I would say with good counseling, good monitoring, it's actually fairly safe in routine clinical practice. And it's now being remarketed with Phenergan as a weight loss supplement. So I think that's a little bit, some people are looking for that, especially if they have IIH kind of thing, the idiopathic intracranial hypertension. So I think it has a bit of a bad rap because of the side effects, but I think it's an oldie and a goodie. And of course, the other medicines, as we know, have a variety of side effects, which I'll leave here for you to review. So these are my aquarium types that I mentioned. And what if I don't want to take any of your toxic chemicals? This goes into the lifestyle counseling that we were talking about. So we go over sleep habits, exercise, diet and hydration, stress reduction. I will give them a prescription with mindfulness links and apps and exercises and things, and give them all of the sleep hygiene, and kind of building up on very gradual walks, like starting for 10 or 15 minutes around the block, and you build it up by 5 minutes every month. And patients are very, I think, responsive to this. So I've seen really good uptake in the lifestyle modification, and then they may not need their medication as much. If you want to review a great article that delves into this, there's a SEEDS model, which addresses all of these things, and it's by Jen Robley and Amal Starling. And I'll have the reference in the slides for you. So nutraceuticals, we need a whole other talk. This is what I was talking about, like easing people into harder medicines that they may be apprehensive about. Starting them with some of the stuff, I didn't want to throw the baby out with the bathwater. I think there's a lot of good things that comes out of more natural or alternative medicine, but you want to back it up with evidence. And these are the ones that have good quality evidence for migraine. So I will often recommend magnesium or vitamin D, CoQ10, riboflavin. And again, here's a good summary of those if you want to delve into the data. Other devices, like we mentioned, they can be used both in acute and preventive options, and they represent a nice way to avoid medicines. And like I mentioned, there's a talk available on YouTube from Migraine Canada about this. So for a long while, these patients were wandering through the desert, trying out one medicine after another with all sorts of horrible side effects. And, we knew Botox was useful, but you had to get over 2 to 3 preventives before you could get there. And so it was a really desperate, frustrating time for a lot of people with migraine. But things have been evolving, and now suddenly we have an explosion of different types of medicines which are available. And because a lot of them are kind of newer technologies like monoclonal antibodies, I think there's an apprehension because the first ones to class like this, these disease-modifying biologics, they were things like for MS or rheumatoid, which required blood monitoring and had very serious potential side effects, or needed imaging and things. And so I think that maybe caused some primary care people to be apprehensive about using these. But the one thing I would emphasize is that they're like exceptionally safe and they're better tolerated than the traditional stuff we're using. So really, they're kind of an ideal medication for primary care. So unfortunately, I think sometimes the pharmacy shelf is looking like the hot sauce aisle in Buffalo, because there's so many options and they're all very attractive. And how do you determine which one to pick for your patient and give them the best outcome? So we'll get into that in a second. Arrival of the new monoclonal antibodies. I think this represents a new hope for our migraineurs. And so there's 3 classes blocking this pathway, like we talked about. There's monoclonal antibodies that block the receptor. There's antibodies that block the ligand, the actual molecule. And then there's the small ones, the GPANs that we talked about, that block the receptor. So they block CGRP action, inhibit transmission, and importantly, to reiterate, they are not direct vasoconstrictors. So, more likely to be safely used in people with those vascular risk factors. So again, for the sake of time today, I'm presenting the data in aggregate. And because the trials are all different in the way they were designed and executed and analyzed, you can't really make a head-to-head comparison, but it gives you a rough estimate. So looking at CGRP monoclonal antibodies in episodic migraine, we have 3 main ones: erenumab, galcanezumab, and fremonizumab. And these patients had kind of lower frequency. They're kind of on the cusp between high and low frequency episodic migraine. And so baseline days ranges somewhere between 8 to 9 for all these trials. And a 50% reduction is kind of an easy, good rule of thumb to explain to a patient. I think it's very intuitive. You can say how many patients, what percentage of patients cut their headaches in half. And I think that's very easy to understand instead of some of the more abstract ways we were measuring it before. And so for erenumab, kind of the flagship one that started first, we were seeing 50% reduction in somewhere between 40 to 50% of patients. For galcanezumab, it was a little bit better, maybe up to 60% there, and fremonizumab 44 to 47. And so we kind of averaged out, and people were saying from this trial data that maybe 50% of people cut their headaches in half, and then maybe 25% cut their headaches by 75%. But I think again, it's important to remember that in a clinical trial, patients are very carefully selected, and they tend to have frequencies of headache on the lower end of the spectrum, and they exclude a lot of the more complicated patients that have other things going on, or continuous opioid use or other chronic pain conditions. So looking at the chronic migraine data, the numbers, like you would expect, are a little less robust because these are people who are in a more difficult bind. Their baseline monthly migraine days are ranging between 15 up to 20 kind of range. And the 50% reductions here are a little bit more modest, so maybe around 40% for Aimovig, around 30% and 40% for Emgality and Ajovy. If you want to give them a rough rule of thumb, you can say for episodic migraineurs, about 50% of people cut their headaches in half. For chronic, about 40%. And super responders, we consider a 75% reduction of headaches. That may happen in about a fifth of patients. And so side effects and tolerability. I would say when I consult patients, I say minor constipation. I will often pair this with magnesium, because milk of magnesia, like you may recall, is an old-timey constipation remedy. I just tell them to very gradually titrate it up until they're having a bowel movement every 1 to 2 days. And when it happens, it's generally mild. Injection site reactions are always a possibility. I mean, a little bit of redness or itchiness is normal anytime you use a needle, but in these rare hypersensitivity reactions, they will develop a very itchy goose egg. And if that happens, they should discontinue it. Other than that, now that it's been out for 5 or 6 years, we've seen maybe a little bit of a signal for hypertension. It's been added to the US label, but not yet in Health Canada. And I think there's definitely a safety signal. It's something I tell my patients to monitor periodically, once to twice a month. And if their blood pressure is going up for no good reason, we may reevaluate. But also to highlight that these data were collected during COVID. And if you look at the study population, the people with the signal were 40 to 60. They all gained 20 pounds during COVID and they weren't exercising. So I think there might be some confounding factors. So, in real life, some people mention fatigue or hot flashes, hair loss. A lot of this you'll read in the blogs, but often when you actually send them for a hair count or a derm referral or things, there actually isn't any alopecia. So some of it is perhaps a little bit suggestible, and the other symptoms may actually just be attributable to migraine. So people will often ask me, well, how do you pick between these mAbs? And, is it kind of like just spinning the wheel? And I tell people, like, the most appropriate one for your patient is the one their insurance will cover. I mean, truly, they seem to be quite comparable. But there are a few little, things to finesse the presentation. So for Iraneumab, this blocks the receptor, whereas the other ones actually block the molecule. It was the first to market. So, if you're failing on one, you might try rationally switching to a different mechanism, even though they're kind of similar. Galcanezumab, the difference is that it requires a loading dose, but a pro is that, it's also indicated for use in episodic cluster headache. And probably because they have similar chemistry, the others might be useful for that too, but this is the only one that demonstrated it with a study. Fremonizumab, at least in Ontario, and I think in Alberta as well, good public coverage. And for those who are traveling abroad, I have many patients going back overseas for months at a time. They can inject themselves quarterly. So that represents kind of a useful caveat there. And eptinizumab, which was just recently released in Canada, it is an IV formulation that has to be done at an infusion center. And what's really neat about this one is that you may see rapid onset results like as early as 24 hours. So this, we're kind of saving for our ultra refractory CGRP people. So how do they compare with traditional preventives? We won't go too in depth in this for the sake of time today, but what I thought was particularly brave of Novartis was often you'll never see a head-to-head trial of the standard of care against a new drug agent. It's always against placebo and done in such a way that it kind of obfuscates direct comparison. But I think they were quite confident in the efficacy of this and designed a useful prospective study. And so it's randomized, double-blind, double-dummy, active-controlled, parallel group, phase 4 califrangilistic trial. And it's looking at German patients with chronic and episodic migraine. And these were either treatment naive or not eligible for up to 3 prophylactics or up to 3 failures. And so I'll just show you kind of a visual of this trial. They had a screening phase to determine eligibility, a baseline phase where they actually characterized the migraines. And then during this double-blind titration phase, they were either given a titration of placebo or topiramate with either the injections of Iraneumab or a dummy injection. And so, it's important to understand the results of this trial, that if you had any side effects of the topiramate or you felt you need to reduce the dose, you weren't allowed to reduce the dose. You had to stop the medicine, but you continued to contribute data in a kind of intention to treat kind of manner. So it's a modified intention to treat study. And so what was interesting was that, watching over time, like cumulatively, people with Topamax, there's a 4-fold difference in the rate of discontinuation due to adverse events. So to my mind, that speaks to the superior tolerability of Iraneumab. And then looking at the efficacy, Topamax here is 31% had the 50% responder rate over that month 4 to 6, as opposed to more than 50% with Iraneumab. And again, highlighting that this includes those people who were no longer taking medicine due to side effects were kept in an intention to treat fashion. So it's the first trial directly comparing CGRP with an established oral preventive, which was the standard of care. And it showed favorable tolerability, lower dropout rate due to adverse events, significantly higher proportion of 50% responders, and reduction in mean monthly migraine days. Oh, and then so we're going back to GPANs, which we've already kind of talked a little bit about in the acute sense, but now I just want to show you very briefly about the preventive use. And so to remind you, the preventive ones that can be used are atogepant and rimegepant. And like I mentioned, they do not cause vasoconstriction, not contraindicated in the context of cardiovascular disease, and they aren't thought to contribute to medication overuse. What are the main differences between the MABs and the GPANs? So the MABs, the monoclonal antibodies, are injections that the patients give themselves once a month or quarterly. GPANs are typically oral and are usually dosed like every other day or daily. The half-life for MABs is about a month, whereas for GPANs it's 5 to 11 hours. So, if you're counseling someone about conception, if you're choosing to have a baby, you've got to stop this for 5 half-lives. That could be 5 to 6 months before you clear your system. So, for young women who are planning families, this could be an important consideration. The MABs are large molecules and the GPANs are small ones, which means like the antibodies have a bit of more difficult time passing the blood-brain barrier. I mean, maybe a minute amount crosses, but not a lot. Whereas GPANs are free to cross and may also have additional central action in the brain. The frequency is different, like we mentioned. And then what's interesting is the MABs, because they're metabolized through endothelial system, they don't have interactions with other medicines in a hepatic or renal sense. whereas the GPANs, do have some interaction with cytochrome 3A4. And MABs are preventive, but GPANs can be used either acute or preventive fashion. So I'll start with atogepant for use of episodic and chronic migraine, 10, 30, and 60 milligrams, but probably the recommended dose is 30 to 60 once a day. There are BID dosing studies in prevention of chronic migraine. And so I would say if you have, other issues with liver disease or renal impairment, you have to consider adjusting the doses. And for your reference, I'll include charts on how to do that. And contraindications, not a lot, really just people who are allergic to any components of the drug or the formulation. Rimegepant, we've already talked about a little bit, so we'll just breeze over this slide. And again, I want to highlight that the safety of using more than 18 days in a month has not been established, although they are looking at this. And you have to be careful with certain medications like breast cancer therapeutics or antifungals, which may interact with it. So presenting the data in aggregate here, you can see for atogepant, they divide it into episodic and chronic migraine trials, whereas rimegepant did something of a hybrid. They kind of included all patients with 4 to 18 migraine days, which is a combination of episodic migraine and low frequency chronic migraine. So the dosing is a little bit unusual for rimegepant. I highlighted it in red there. It's dosed every other day. And if we're looking at the baseline headache days for atogepant rather in the advanced trial, it got about 7.5 to 8 days per month. And in the more chronic migraine, they were higher, closer to 20 days per month. In the rimegepant kind of hybrid study, they're somewhere around 10 days a month. So still kind of episodic frequency. And the reduction in days, looking at the 50% responder rate, some are ranging between 40 to 50%. But when you compare to placebo, we get numbers needed to treat ranging from 3 to 7 for atogepant, up to 12.5 for rimegepant. So I think, compared, it's a little bit more favorable for the atogepant there, but we can crunch the numbers differently. For adverse events, I would say constipation, nausea are pretty common, and these are very similar to what we saw with the monoclonal antibodies. In general, when they do happen, they tend to be fairly mild. Otherwise, the drugs are very well tolerated. Adverse event for rimegepant, kind of a similar thing, but more with nausea, nasopharyngitis, things like this. And again, very well tolerated. The out-of-pocket cost, again, we don't have the Canadian prices for these. And just to reiterate, US prices are typically higher than here. Rough estimate, atogepant is somewhere around 1,000, rimegepant 1,000. And if you contrast that with Botox, again, it depends on your plan, but about $700 to $800 for the medicine, an injection fee of $200. I've seen even $450 in Toronto or something. And that adds up a lot. So you'll have to crunch the numbers and see what the coverage is like. And so unfortunately, this kind of calculus factors into patients' decisions to pick a medicine when it really should be clinically determined. Contrast that with Topamax, and you can get that for $26 a month, but you do have to kind of go through the hassle of that kind of very gradual titration and potential side effects. So what's on the horizon? I've listed a bunch here, and they may seem like a bunch of kind of random words, but I would say the most interesting one coming up for me right now, I've been reading a lot about, is PACAP, which is pituitary adenylate cyclase activating polypeptide. There's a number of agents looking at this and antagonizing the pathway. Psychedelics and various congeners of this are very useful. So psilocybin and psilocin in Ontario, we've started a number of trials now looking at chronic migraine, and it's now also receiving multiple exemptions from the health minister for refractory depression, MAID, cluster headache. So it's a very exciting time for that kind of research. And there are lots more that are in the works. So stay tuned, because I think, this is the one message I want to have you pass on to your patients, that there's a lot of hope. I think a lot of people give up on their treatment for migraine and leave feeling that they tried a bunch of drugs and they didn't get anywhere. And it can be a long and frustrating road, but I think there's lots more options that are coming that may be useful for them. So send them to Migraine Canada. They can get all the updates on everything that's coming up. So in summary, new treatments have arrived to market, more are on the way. The monoclonal antibodies are effective, safe, and well tolerated. You can use them for chronic or episodic, and they're better tolerated than most of our go-to oral preventives. Truthfully, they are a low maintenance kind of drug. It doesn't take titration, not a lot of monitoring, maybe blood pressure periodically. And so should be safe across all clinical settings. GPANs are the next generation of these antagonists. They're also safe, effective, and well tolerated, for acute and preventive use, which is kind of an interesting thing that's kind of changing the way we think about it. And the other option is layering medicines. So I know like there's a lot of hate for taking too many medicines, but sometimes combining therapies in rational ways where you take different pathways that potentiate one another, 𝐂𝐑𝐈𝐁𝐄 and Botox and, throwing in a little bit of something else, gabapentin or something. I've had unique combinations like that that have significantly improved people's migraine frequency and quality of life. So I would say, although it can be difficult conversation, it's important to consider that. And like I mentioned, rational combinations of these are kind of like still to be determined. There's some data trickling out about combinations of Botox and CGRP, which seems to be an interesting combination therapeutically, and then combining GPANs and MABs. So stay tuned because there's a lot of this now showing up at the conferences. And I think the issue, like I mentioned before, will be cost as a barrier for our patients. But eventually, I think, there's hope that they will gain access to this. And lastly, lifestyle advice, nutraceuticals, the stimulators, something that you can offer your medication hesitant patients. So please feel free to use my slides or use those references. And I think they'll go a long way to helping your folks. So I want to thank you for your time and attention. And if we have any other questions, I know we kind of went a little bit over time. I'm happy to field any of them.
Hello again.
Hi.
No, you're right on time. We have till about 12:15 if we want to have a few questions. And
Perfect.
so I just want to thank you for taking us from acute medications to the prevention, which sometimes we forget about preventative health, and that can be another topic. But in any case, we do have a few quick questions. So we have a question regarding the GPANs. Can they be used for acute migraine if you're on a CRGP blocker?
So yes, well, here's the thing. We have no clinical data showing this. And honestly, personally, as a disclaimer, I have not personally prescribed this because they're not available in Canada yet. But I have some friends in the States who I know have combined this. And they have even told me that patients have double doctored and gotten separate prescriptions and they combined it. If you go back to the primate studies, when they looked at the very first day, like tolerability, trying to ballpark where a dose might fall for a person, the doses they selected were well below the safety threshold. And so it seems like there's a margin that could be used. But again, this is going off label. And so I think it's possible. And I think future trials will be examining this. And that's why I'm excited. We're going to Scottsdale next month. And hopefully we're going to collect some data on this. So I'll be able to report back to you.
Wonderful. And appreciate the fun slides that you had about, it looked like we were in the desert and we had some signs and we had
they've been wandering the desert. Yeah, 40 years. No, I don't know. Like 30 years since triptans came out. I don't know.
It's probably been a long time, but nevertheless,
yeah.
Just a point of clarification or just a curious question here. For NSAID use, the person is just asking, and I think that they might be a pharmacist, but we'll see. Wouldn't naproxen sodium, the 550 milligrams, be a better choice than regular naproxen 500 milligram base? And the basis for that question comes from the sodium formulation dissolves faster in the stomach and reaches peak plasma concentrations an hour faster. So any comments about that?
Yeah. Actually, my reading when I read about this different salts was in the context of Cambia and the potassium versus sodium salts. But yeah, it definitely affects the absorption. So I think that's a rational, that's definitely a substitution. But still, comparatively, I would, if they can afford it and they have coverage, I would go to Cambia because the peak of onset is still superior even to the sodium salt for naproxen. But it is a lot cheaper and so perhaps more cost effective for some people.
Yeah, and I know we always have to balance that cost and coverage. I know for some folks on provincial plans, Cambia might not be a benefit. So we always have to look at asking the question, because sometimes even if it's not a benefit, folks might be very interested on how we not promote it, but how we present it. That faster onset of action can speak volumes for someone who's having an episode that is just not very pleasant.
And samples. I mean, samples are a great way to cut down the cost. And so, I think Miravo reps are very happy to provide you with some samples of Cambia and Suvex. And that can go a long way to cut down, maybe 50% of the cost of the prescription to supplement it. It's a good way to do it.
Sounds good. We have a few moments before I'm just going to send everyone for lunch in the sense of having some breaks. I want to land on a question that's a fairly broad one, but an important one. Yesterday, if you were in attendance, we spoke a lot about stigma, how folks living with pain can be experiencing stigma, from different areas. And so the question here is, how can we reduce the perceived stigma of migraine so people might feel less judged by society? And you can take that in any regards that you'd like.
This is a very difficult one because a lot of times with migraine, the stigma is also internalized. So I find that like people will say, they grew up in like a very stoic family where they're like, well, it's just a headache, you have to deal with it or something. And so they may go many years before they seek attention at all, and they're suffering in the darkness of only going out half of the days of the month or something. So I think it's all about education. It's about showing people, connecting them through community. So I think like Migraine Canada has done a very good job of that. It's a great resource where it's not just clinicians. I mean, it's mostly driven by patients. And so you can talk to people who have had the whole gamut of all the rare variants of migraine, and they will tell you that, no, you are not insane. Your vertigo and brain fog and all these things that you're experiencing are actually part of a neurochemical imbalance in your brain, and we're going to find some options to help you manage it. And so I think it's even better to have it coming from other patients because, sure, doctors, nurses, physician assistants are a good trusted resource, but for some people to gain that little extra nudge of trust, they need to hear from another person who's experienced. So I think that's part of it. It needs to be represented better in media or in movies, things like this. I mean, it's just not represented, but this is such a common problem. It's a fifth of people. So, it's funny when you actually start to talk about it with people in a family setting or anything, like they'll admit that they have headaches, but they've never told you for years. And you're like, you're a family member. This is really unusual. So I think just opening up that conversation. And the other thing I find is like employers are very frustrated by migraine because you may be missing up to half the days, and people go on disability because of this, often before they've even tried any treatments. And you're like, oh, well, that was kind of a missed opportunity. And so I think they will say, well, come on, it's just a headache. And they're thinking of their little tension headaches that they get, but they don't realize how truly disabling a migraine can be. So I just want to hit home, like, even if you have migraine, it's a spectrum. You may have a very mild type of migraine and you may not understand what they're experiencing. So you will see that patient that comes in and they decide to come anyway that day, and they're like wearing their goggles and a cowl, and they look like they just got hit by a car, and it really is terrible. And then you give them that medicine and they're fine 2 hours later. I think it's a real opportunity to teach them that they don't just have to suffer in the darkness. I don't know.
I think that starts the conversation really well. And to your point of just asking and just, sharing the fact that, you mentioned that you live with, experience headaches too. So I think it starts with all of us, and it's a well-placed question, can get the conversation, and someone who can be a champion. And who really, the person that you're working with or serving, you feel safe to share and disclose that information. So yeah, thank you. We covered the many different gamuts here. So the GPADS, boy, you pronounce those so very well. I was like, oh my goodness, I can't attend to that very well, but we really appreciate you joining us from London, Ontario, that is, and we look forward to keeping in touch. So thanks again, Alex, today, and enjoy the rest of your weekend on your Saturday, and yeah, take good care. And I will just have a few brief messages for our attendees here, but take good care, and thanks for joining us.
My pleasure. Take care.
Wonderful.